Okay, next we have Dr. Helen Heslop. Helen is a professor of medicine and pediatrics at Baylor College of Medicine and an interim director of the Center for Cell and Gene Therapy. And her research has really focused on adoptive immunotherapy and using that to study hematologic stem cell transplantation and cancer therapy, and that will be the topic of our discussion. Thanks.
Thanks, Lee. These are my disclosures, none of which are relevant for this talk. So in the last talk, you heard a very thorough discussion of both the benefits and limitations of preclinical models. And really the same issues apply to adoptive cellular therapy, in that in vitro studies are not always predictive. If you use fully murine models, you have the challenges of different immune systems, and target antigens aren't always similar. And immunodeficient mice can graft human tumors, but lack immune components, so they're not predictive for off-target effects. And these issues are particularly challenging when targeting viral as opposed to tumor antigens. So this is a quote from a review of immunotherapy by Merlo et al. A few years ago, and they expressed some surprise that the whole area of EBV-specific T cells had advanced without a rigorous animal preclinical evaluation. So what I'd like to do in this talk is explain why it was challenging to have an animal model for viral-specific adoptive immunotherapies, and how this approach has nevertheless advanced to the clinic, and also tell a cautionary tale of how some preclinical studies did lead to findings that were not translatable to the clinic. So as a transplanter, viral infections post-transplant are a major cause of morbidity and mortality. And while we have pharmacologic therapies, they're not always available for all viruses, and there are recurrences when therapies are stopped. So T-cell immunotherapy is an attractive alternative because the risk for these viral infections is clearly related to the lack of a virus-specific T-cell response. So the strategy that we evaluated was to generate virus-specific T cells by repeated stimulation with viral antigens expressed on antigen-presenting cells. So the virus-specific T cells, which were low frequency, shown here in orange, would expand, and other specificities such as alloreactive cells would not be selected. Now, we initially evaluated this approach in EBV lymphoma because in the 1990s, when we were doing selective T-cell depletion for our transplants from mismatched family or unrelated donors, we were seeing an incidence of this complication of around 10%. And this was basically because we were transferring EBV-infected B cells, which would normally be highly immunogenic, in the absence of the EBV-specific T cells that would normally control them. So we devised a strategy to reconstitute the immune system by generating T cells from the transplant donor, by firstly making an EBV-transformed LCL, which had the same phenotype as the outgrowing lymphoma, and then using these irradiated cells along with cytokines to expand tumor-reactive T cells under conditions where alloreactive cells should not survive. So at this stage in the 1990s, there were preclinical models in immunodeficient mice for EBV lymphoma, and our collaborators, Julia Hurwitz, showed that both CD8 and CD4 specific T cells had activity against EBV-transformed tumors in SCID mice. But there was no good model to assess the risk of alloreactivity or other complications. So when we submitted our IND to the FDA in 1993, we explained that there were no suitable models. We submitted human preclinical data, and the FDA came back to us with some concern, as we expected, about the risk of alloreactivity, and requested data on the risk, and that we provide an assay for alloreactivity as a release criteria for the lines that we were going to infuse. So to address the risk of reactivity, we discussed the fact that these T cells were manufactured from the transplant donor, and this donor had been chosen by the transplant team as the best available match. We performed a dose escalation study, and the initial dose that we used was less than that used in studies of unmanipulated donor lymphocyte infusion. And we explained the culture conditions should select against alloreactive cells. There were no validated assays for alloreactivity, So we decided to actually do a cytotoxicity assay and manufacture PHA-transformed blasts from the recipient and use this as a target in a cytotoxicity assay. And the release criteria we chose that there should be less than 10% killing. So we used this assay in over 100 lines in our first study, and we only actually had one line that was a major failure. It had cytotoxicity of over 50%, so we didn't administer this line. And of note, the patient who received the product from the donor developed severe GVHD after their transplant, so there was obviously a high degree of alloreactivity between this donor and the recipient. But in all other cases, this was a suitable release criteria, and our only limitation was that we couldn't manufacture PHA blasts from patients with immune deficiency, and in that case, we used parental cells. Now, these studies showed that this approach did have clinical activity. It could restore virus-specific immunity and cure disease in over 80% of patients with active lymphoma, while providing long-lasting protection with low toxicity. So our next series of viral-specific T-cell studies, we aim to extend the spectrum of viruses targeted, so we also included CMV and adenovirus, because these were other common complications post-transplant, and most donors were immune. So we changed our manufacturing, so we were now using LCL as antigen-presenting cells for the second stimulation, but for the first stimulation using monocytes genetically modified with a vector that expressed the CMV antigen PP65 in an adenoviral vector, so the responding cells saw antigens from both these viruses, and then we used LCLs for subsequent stimulations, so they also saw EBV. And by this process, we generated trivirus-specific T-cell lines. So at the stage we submitted this IND in 2003, we still had the immunodeficient mouse models for the EBV component that we could model anti-tumor activity in, but of course we also had clinical data at this stage. We still didn't have a way of modeling GVHD, and there were no good murine models for multiple viral infections post-transplant. So the FDA accepted our preclinical data and the study proceeded, and actually also showed significant clinical benefit that we could reconstitute antiviral immunity against all three viruses and also clear established disease. This is a patient with adenovirus pneumonia, which resolved after receiving the T cells and remained in sustained remission. So to try and make the approach more broadly applicable, we then asked whether we could use off-the-shelf third-party virus-specific T cells, choosing the line from the most closely matched donor. And this slide just shows that you can make the lines from a number of different donors and characterize both the HLA specificity and the viral specificity of the line. So one line may potentially treat several potential donors who have different viral infections restricted by different HLA types. So we evaluated this strategy in a multi-center trial supported by the NHLBI. And when we submitted this protocol in 2008, we felt in this situation there was a higher theoretical risk of alloreactivity because we weren't using the transplant donor. We were using the most closely matched donor. We set the study up to treat refractory disease, so the whole strategy of using the PHA blast release criteria was no longer feasible. Firstly, because the manufacturing time would have precluded us treating patients in a timely manner, and second, because these patients were post-transplant and there wasn't always available pre-transplant blood to make the PHA blasts. So we proposed that we did not have a release criteria for alloreactivity since the patients had serious disease, and this was accepted by the FDA. So this study also showed clinical benefit. The response rate here was not quite as high as in the donor-specific lines, but was still 70%, which proved beneficial for patients. Now, around the time that we were doing this study, a paper was published from a group in Holland where they looked at alloreactivity of virus-specific T-cell lines. And they used a different assay to the cytotoxicity assay that we were using as a release criteria, and they instead measured gamma interferon production in response to stimulation with allo HLA molecules. And when they used this assay, they found that over 90% of virus-specific lines and 45% of virus-specific clones cross-reacted against HLA molecules. And they used TCR transfer to confirm that the anti-HLA reactivity and the virus specificity were mediated through the same TCR. So when this paper came out, we obviously had to look whether our virus-specific T cells were alloreactive using a similar cytokine release assay. So we collaborated with Joss Mellenhorst, who was then at the NCI, who had such an assay set up. And he had a panel of 44 T antigen presenting cells, and we used these unlabeled cells to stimulate some of our representative virus-specific T cell lines, and then measured responder cells that produced TNF and gamma interferon. And we found that our lines, both the CD4 and CD8 components, also displayed moderate reactivity in this assay, with reacting at an average of 1 to 5 of the antigen-presenting cells that had the recipient's HLA allele. But when we looked at whether there was alloreactivity in vivo, and at this stage we looked at 153 donor-derived lines, of which 28 were haploidentical and 43 were unrelated antigen donors mismatched at one or more antigens, we actually saw a very low risk of graft versus host disease. So no patients developed de novo graft versus host disease after receiving our virus-specific T cells, and there were some patients who had reactivations, but the rate was around 10% overall and not higher in the recipients of mismatched transplant. And this is not an increased incidence compared to what you would normally see in transplant patients with previous GVH. So here, with this whole issue of alloreactivity, the in vitro assay with using cytokine release as an endpoint was not really predictive for in vivo reactivity, highlighting that preclinical studies don't always predict what's happening in the clinic. And I think it also illustrates that we were very lucky that in the 1990s we chose a cytotoxicity assay, because at that stage gamma interferon was more complex to measure. If we'd made the same decision about 10 years later with the increasing availability of cytokine assays, we would have made a different choice, and many of our lines, in fact the majority of them, wouldn't have met a release criteria. So what about other complications? Cytokine release syndrome is obviously well described in patients receiving chimeric antigen receptors. It's relatively rare in patients in our study. We looked and we could only find 2 out of 166 cases. And here, with the native receptors recognizing viral antigens, it seems to correlate with bulky disease. This is a patient who developed PTLD after a mismatched unrelated donor transplant that was progressing despite rituximab. She received EBV-specific T cells, and you can see the EBV DNA returned to 0 over a couple of weeks. But during the time that she was having the clinical response, she developed fever and hypotension requiring 2 inotropes and had an increase in multiple cytokines, and this resolved rapidly after steroids and an anti-TNF agent. And clinically, there was an impressive response as shown here. The other adverse event that we've seen in patients who respond to virus-specific T cells that wouldn't have been predicted by preclinical studies is inflammation during response. This is shown here for a patient who received T cells targeting BK virus. You can see that they received T cells, had an increase in T cell activity in the blood, and during the clinical response, the patient's pain got a lot worse, so they had a cystoscopy, which, as you can see here, shows marked inflammation, and a biopsy showed that the material contained BK-specific T cells, but not T cells reactive with other antigens. So when you have very bulky disease, you can also get inflammation during a therapeutic response. So looking at the whole issue of alloreactivity by putting our studies together with studies from a lot of other investigators, I could recently find over 450 patients in over 30 studies, and only 58 patients developed graft versus host disease, which was mostly grade 1 or 2. And I think this is similar to expected in patients post-transplant who reactivate graft versus host disease. Looking at the third-party studies, there's, if anything, less graft versus host disease, perhaps because the cells don't persist so long. And you can see that the overall responses range from about 60 to close to 100%, and again, only very small numbers developing graft versus host disease. So I think although these studies were developed without animal preclinical evaluation because there weren't suitable models, they were able to progress such that they produced beneficial effects for patients in a reasonably safe manner. So in the last couple of minutes, I'd just like to talk about extending this approach using T cells recognizing native antigens to lymphoma. And the challenge with lymphoma is it's a heterogeneous tumor with multiple different cells expressing different target antigens. So the approach that Anne-Leen and our group has developed is to manufacture tumor antigen-specific T cells that recognize multiple antigens expressed on lymphoma cells. And shown here are the 5 antigens that she's chosen to target. So when this clinical study was submitted to the FDA in 2011, we submitted the preclinical data showing that the lymphoma cells expressed these antigens and they could be killed in vitro assays when the target cells were cultured with the tumor antigen-specific T cells. Again, there was no suitable animal model to evaluate this strategy. So we were actually a little bit surprised when we got put on clinical hold and received a letter from the FDA asking us to more closely evaluate the risk of cross-reactivity and perform analyses for homology of the target antigens and other proteins. And the reason for this query became apparent shortly afterwards when Dr. Rosenberg started presenting the data from the NCI, which showed they'd had cancer regression, but also severe unpredicted neurologic toxicity when they'd used an affinity-optimized TCR targeting MAGE-A3. So to address this issue, we first of all did homology searches and then also provided information on the differences between native antigens and optimized TCRs. But we also proposed that we design the study as an antigen escalation study, starting off with 1 antigen, then moving to 2, 3, 4, and 5. And we've now completed the antigen escalation phase and are on the phase of the study where we target all 5 antigens. I just want to show data from one of the patients who was early in the study and received T cells targeting 2 antigens. This is the patient with Hodgkin's lymphoma with residual disease. She received T cells targeting at this stage of the study PRAME and SSX and had a marked increase in activity against these 2 antigens measured by ELISpot after infusion. But of note, she also had an increase in the activity against multiple non-targeted antigens expressed on lymphoma cells, including several other members of the MAGE family, but no activity against WT1, which is expressed on myeloid leukemia cells, but not lymphoma cells. And this correlated with the clinical response. So I think that although you can predict activity against the targeted antigens from preclinical studies, phenomena such as epitope spreading are much harder to model. So in conclusion, I'd like to say that with both the virus-specific T cells and the tumor antigen-specific T cell strategies, there are limited preclinical models to assess alloreactivity and other risks of such therapy. Some preclinical models didn't correlate with the in vivo effects. And to some extent, you're going to need clinical testing to really assess both the benefit and potential risks of these therapies. And I think strategies to reduce risk in clinical testing include starting with low doses, if appropriate, strategies such as the antigen escalation, having intervals between patients enrolled, and then also having the ability to ablate the cells or neutralize the cytokines if adverse events occur. And obviously steroids as a way of ablating such cells, anti-cytokine strategies have proved effective, and a suicide gene is another potential strategy. Thank you.